Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the HELONC podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
I'm Dan.
And in today's episode, we have a very special guest on our show, Dr. Amar Kelkar from the Dana-Farber Cancer Institute. You guys may remember him as a part of our show back in the myeloma series, and he's back again today to kick off our two-part episode on AML transplant.
Yeah, really excited to get into this one. You're going to learn so much here that, as a malignant hematologist, I picked up so much from these episodes that will be coming out on consecutive weeks. So everybody, seriously, check it out. Check out our website and show notes. We're going to summarize some of the high-yield information in a succinct manner, so that way you can all follow along. And if you ever have that transplant patient, you can go back and look at it and say, oh yeah, that makes so much sense. He breaks it down in such an understandable manner.
And as we were recording this, we literally lost track of time and got so wrapped up in our discussion that we're going to end up having to split this into two episodes. So hopefully y'all have the same reaction and feel just as engaged as we did.
Let's not keep them on the edge of their seats much longer. Let's roll that show. We're so excited to have a guest on our show today. We have Amar Kelkar, who is an instructor in medicine at the Harvard Medical School and a physician at the Dana-Farber Cancer Institute, specializing in bone marrow transplants. You guys may remember that Amar was on our show for our myeloma series a while back, and we're really, really excited to bring him back this time to talk all about allogeneic transplants. Amar, welcome back.
Yeah, thanks so much for having me. I'm really excited to be back here with you guys. We had a great time last time and looking forward to talking transplant.
And as you may recall from last time, we always like to ask our guests to share one fun fact about themselves. Hopefully, you've got another one up your sleeve this time.
Yeah, actually, we just had a kid, our first kid, a son named Sahan, who is 1 month old as of this week. So I'm just coming back from parental leave right now.
Yeah, I don't no idea how you're on the show right now. I mean, the sleep deprivation, but what's going to be amazing as we go through this, we're going to see how great Amar is because he's somehow doing this on like zero sleep. So congrats. I mean, how's it been being a new parent?
Very exciting. Honestly, it's a life-changing experience. I think that's a common refrain, and it definitely held true for us. Thankfully, happy, healthy baby and lots of diapers and late night feedings.
Hopefully the sleep will be increasing in the near future, at least in the next 6 to 8 months.
We'll keep our fingers crossed for you, Amar. But in the meantime, again, thanks for being here. Vivek, do you want to start us off with the case?
Yeah, let's get started. So just very briefly, let's say we have a 55-year-old male with FLT3 ITD mutated AML. His NGS ended up showing both a FLT3 ITD mutation with a VAF of 45%, as well as an NPM1 mutation. So he underwent induction chemotherapy with 7+3 plus midostaurin based on the RATIFY trial, and he achieved a CR. So we're planning for an allo transplant in this guy. And, we always talk about this, but we sent his HLA typing for transplant. He's seemed like a fit guy, a good candidate for transplant. So today we're going to focus this episode on the nuts and bolts of allo transplant. We spent this series really getting to this point, talking about all of the details on how you get somebody to transplant. And then it's like that black box, right? We hand off this patient to our transplant colleague, somebody like Amar, who's doing all the hard work after that. So the first thing I want to ask is, let's start off with transplant eligibility. So in your mind, what are the key factors when we think about transplant eligibility? Because that's a really hard thing to digest. And what are you looking at when you see that patient?
I think that's a great place to start. And I try to bucket this into two areas. One is medical eligibility in terms of, or I should say disease-specific eligibility. And then the other part is eligibility in terms of their overall health. You talked about fitness, so we'll talk about that in a second. But I think the first thing I usually look at when I get a patient is, and in this case, this patient has AML, is what kind of risk group that they fall into. The patient you described would fall into likely an intermediate risk group based on different criteria that I've come across over time. And I can't recall if you guys have talked about this in past episodes, so I'll just review this for the group. But generally for patients that are intermediate risk and higher, those patients have traditionally been the ones referred for transplant. When we think about AML and intermediate risk, or I should say favorable risk, which is the one group that would not be immediately forwarded to transplant, we're thinking about translocation 821, which is a RUNX1 rearrangement, NPM1 mutations without FLT3 mutations, and CEBPA mutations that are either biallelic or more recently have this BZIP in-frame mutation. And so all patients that don't fall into those groups tend to get forwarded to transplant like this one. Now, there was a guideline change in the last few years. So back when I was a fellow, the 2017 guidelines were still in effect. And in those guidelines, NPM1 mutated AML had low allelic ratios, less than 0.5. And this is an allelic ratio for FLT3 ITD, which is that internal tandem duplication, where that group that had the low allelic ratios were also in that favorable risk group. And then for patients with either high allelic ratios or had wild type NPM1 with FLT3 ITD, those fell into higher risk groups. Fast forward to 2022 European Leukemia Network guidelines, which now have recategorized and simplified this in some way. So we're talking about patients that have NPM1 mutations without FLT3 ITD that are favorable risk, and then all other FLT3 ITD, regardless of allelic ratio, are intermediate risk. So hopefully that simplifies things for folks thinking about when to refer patients in this particular group. And then one other nuance that I think is useful for folks when they're thinking about this is there was a recent pooled analysis published at the end of last year that looked at NPM1 status and MRD status. And we'll talk more, I think we're going to probably talk more about MRD status later. So I don't want to get too much into that, but basically found that patients with specifically with NPM1 mutations without the FLT3 ITD that were MRD negative were another group that could avoid transplant, but those that were MRD positive might benefit from transplant, or those that have certain high risk secondary mutations might also benefit from transplant. So there's more nuts and bolts, or there's more details there. And I know this is a nuts and bolts kind of episode, so we don't need to go into that, but definitely a lot of interesting fodder for discussion.
Yeah, and those disease-specific criteria are so critically important, and that was a great recap for our listeners. If you listen to our last couple of episodes, we cover a lot of these details into more depth, including that really interesting study when we were looking at MRD testing. We'll get to that a little bit later. So now we have this bucket of disease-specific criteria. How do you go about now? Let's say, okay, this is the right patient, right disease. How do you go about knowing that, hey, this person's going to thrive with transplant? This is going to be safe to give them an allo transplant. How do you think about that?
Absolutely. So this particular bucket, then we think about, I kind of divide it into implicit, or I should say explicit factors. These might be things like comorbidities. And the classic way that we look at that is the HCT-CI, or also called the SOAR score. And this is a 0 to 26 risk score that categorizes patients based on certain comorbidities that add points to that risk score. And after a certain point, we tend to think of patients as potentially being too high risk. Interestingly, this risk score is also integrated into how centers are rated based on their transplant outcomes. So it's a particularly important score to pay attention to. This score considers things like history of arrhythmias, other cardiac comorbidities, inflammatory bowel disease, rheumatologic disease, peptic ulcer disease, elevated creatinine or transaminases, active infection at the time of transplant, moderate or severe pulmonary comorbidities, prior solid tumors, and heart valve disease. And a lot of studies have looked at what is kind of a magic cutoff at this. Traditionally, we thought of scores as 5 and above as being higher risk patients that might warrant some reconsideration, and over 10 to be particularly difficult to justify taking the transplant. We had just looked at our internal numbers on this recently, actually, and saw that for patients that had a higher score, of which 3 points come from a prior solid tumor, for patients that had more distal solid tumors, meaning that may have been treated and cured far in the past, like say of old prostate cancer or old breast cancer, that did not add a considerable amount of actual risk to their transplant outcomes. We've kind of think of that as deprioritized a little bit in practice, but overall, these are kind of important factors to consider. And then there's other center dependent things like the age. So some centers use a hard cutoff of 75 years old for transplant. Other centers like ours at Dana-Farber have a softer cutoff. So we do transplant some patients over 75. And I'm actually doing a study on this right now, looking at our outcomes for patients with transplants over the age of 70. And then there's things like caregiver availability. Again, that can sometimes be a hard cutoff for some centers versus other centers that might take that on the patient's word. I personally have over time definitely become more and more guarded about caregiver availability, because for a lot of transplant centers, they have patients coming from very far away. And so for patients that need help with transport, that need help with managing medications, their transplant, it really has a huge, huge impact on their outcomes. And then there's other implicit factors that we think about. Health literacy, I don't think it should ever be a hard cutoff, but it's something that we really need to consider when we have higher risk patients about how we communicate them and how many resources we put into compensating for gaps in health literacy, extremes of weight, potential social factors of which all patients will need to go through a evaluation from a social worker, and then prior things like solid organ transplant or autoimmune disease. Solid organ transplant usually is a pretty tough thing to justify, although we have done some transplants for patients with prior lung transplants or kidney transplants, especially with sickle cell disease. And certainly autoimmune diseases, while it's one of the risk factors in the source war, can be something that can actually be cured with transplant. And so it's not necessarily a hard cutoff, but something that we really need to seriously consider. And then patients with things like stable advanced renal disease, we often can overcome that with dose adjustments of chemo.
That was super comprehensive. And I think it really does lay out a great list of things for us to consider when we're sending patients over to you all. But I think what I'm hearing, though, definitely is that if we certainly think that patients pass on that initial assessment based on what you described, it may be worth at least sending them over to get a second set of eyes. And you guys can use more of these metrics and these scoring systems to better assess someone's outcomes, which is super helpful. And so, Amar, let's say that our patient had HLA typing sent and now has two possible matched unrelated donors. We've heard that we match HLA A, B, C, DR, DQ, and DP, and each has two alleles. And the perfect match would be a 12 out of 12 because there's 6 HLA loci that we look at. Can you sort of explain why this is important and how donor selection actually works, and just help us better understand some of this alphabet soup?
I love this question because it's, I think, something that shows up a lot on both boards and clinically in practice is definitely difficult to learn. I'll try to give some pearls to kind of help navigate some of these reports so that when you look at these, either for a patient that you're seeing, if you're going into transplant, or if you get referred one of these patients, it might be helpful to you. So again, to the point that you were making, we're talking about primarily 6 HLA loci of particular importance, of which we tend to think that most patients should have at least 2 copies of this, one from mom, one from dad. There can be more sometimes, but we think of it as 2. So there's 12 genes that we're looking at as part of this. There's your class 1 HLA molecules, HLA, B, and C, that are the most important factors to match because they're present on all nucleated cells. And if you look back in old BMT literature, traditionally we match based on those 2 copies of those 3 genes. So you would see 6 out of 6 matches in really old transplant studies. But over time, as you guys mentioned, we've added on more factors that have helped us get better matches as a result. So the other loci of interest, DR, DQ, and DP, are all class 2 HLA molecules. So they're primarily seen on antigen presenting cells. And so you can have a little bit more specificity. When we went from 6 to 8, so 6 out of 6 to 8 out of 8, the gene the first one we added was HLA-DR. And we typically focus on HLA-DRB1 as a gene locus, which encodes the beta chain of HLA-DR. And this is because this is the gene that has the highest degree of genetic variability. And so with that genetic variation comes larger immunologic impact on risk for rejection and GVHD. And so that's why we look at HLA-DR1. For DQ, when we added that, we went to 10 out of 10 as what was considered a full match. And of that, the beta chain gene, DQB1, was considered the most immunologically impactful gene there. And it actually is co-inherited very, very consistently on the same haplotype as DQA1. And so we don't typically look at DQA1, even though you'll often see it on reports. We tend to look at DQB1. And then when we went to 12 out of 12, we added HLA-DP, of which HLA-DPB1 was the most diverse component. And this gene has one of the highest amounts of genetic polymorphism, or at that locus, I should say. And because this was added so late, and because it tends to have less of an impact as the other genes, matching is a little bit less stringent there. And there are actually permissible DPP1 mismatches. And actually, if you use the calculator on the NMDP website, you can actually determine which are permissive and non-permissive to help better figure out which patients have 1 or 2 DPP mismatches, well, typically 1 mismatch, that might essentially function as a fully matched donor, even though they technically are mismatched at one of those 12 loci.
That makes a lot of sense because I've heard both 10 out of 10 and 12 out of 12, and I was wondering, okay, maybe this is just a direction we're going where we're starting to match more of these, but it does sound like that HLA-DP antigen maybe just has a little bit less impact.
And generally, some centers in Europe, they still primarily go by the 8 out of 8 match, which just had the ABC and DR. And so when you think about a 7 out of 8, that's kind of the group that you're thinking about is what is considered to be truly that's when you really get into mismatched transplants from a like international research perspective.
That's so important to understand that distinction too, because we see a lot of research from European groups and others, and it's good to have that context. And of course, all of this is aiming to maximize our graft versus leukemia effect and minimize that graft versus host disease. And so why is a sibling matched donor considered sort of more ideal? Can you tell us a little bit about male to female or female to male? Does this have any impact on GVHD and GVL? Like, what are the other factors besides just matching that seem to influence this?
Yeah, no, that's a great question. It's actually one of the questions that I think is being reopened as we're getting better and better at matching unrelated donors. Each sibling has a 25% chance of matching. This is your classic kind of Punnett square math, of which, one of the advantages of having a matched sibling compared to a matched unrelated donor is that there's multiple minor histocompatibility antigens that more likely to be matched, or at least matching at one of the haplotypes, compared to unrelated donors where you're likely to have more of these minor histocompatibility antigen mismatches. So theoretically and in practice, that confers a lower risk of graft versus host disease for the matched sibling donors, and that translates to better overall survival. Now, there hasn't been a large study comparing with this higher degree of major antigen matching of related to unrelated donors. We just looked at our own internal numbers recently, and I believe we're planning to publish those, comparing particularly groups of older related donors to much younger. So say like 16 plus year old related donors to kind of young, like 18 to 25 unrelated donors, which is one of those questions because age also can play a huge role in the unrelated donors for potentially being better for better donors and better outcomes for patients. But even comparing that young unrelated donor to the older related donor in our own set, we still saw better outcomes. So better, lower GVHD, better GVL, better survival in that older related donor still. So right now, that's still the gold standard. I think there are times when we run into issues, especially patients that have relapses, maybe getting a second transplant or things like that, where we may think about wanting to intentionally select for some degree of mismatch. I think that's a really complicated and open question, so we don't need to get too much into that. But that's kind of one of those few open areas where I think it is worth considering potentially taking a small amount of mismatch to try and induce some additional GVL, though. And then to your question about female versus male donors and recipients, the main difference that we tend to look at are male donors with female recipients. There isn't considered to be much of an issue. But when you think about female donors to male recipients, or just female donors in general, actually, I should say, there is some higher risk for chronic GVHD and potentially some worse survival outcomes seen with this particular risk factor. And it's primarily in multiparous or women that have been pregnant multiple times donors. And that's because there is a minor histocompatibility antigen coded into the Y chromosome that can be targeted. So women that have had multiple children potentially been exposed to that Y chromosome in one of their children, that tends to be where that likely is coming from.
That's pretty fascinating because I actually had a patient who had TALL, had a matched sibling donor from his sister, and he's dealing with chronic GVHD. And I had looked it up and I'd seen this, which I thought was really, really fascinating. It's so interesting how this donor, the immune system, everything you guys are doing, it's like totally like science fiction when you really think about it.
One point I didn't want to just chime on that, and just to that point of your example, is that that could definitely have been the reason why that happened. Or also there's lots of other reasons why people develop GVHD. But most importantly, and I tell this to every patient, which is that the best donor is the available donor. And this is true when we talk later about, say, source of cells, or in this case, donor type or matching. Like the first thing you need for any transplant is a donor. If you don't have that, you don't have even the option on the table. And so this is where we try to get all the things balanced as we can. But at the end of the day, sometimes we have to take donors that may contribute some small amount of risk factor. And oftentimes there's no issue for patients. And then sometimes there is.
Yeah, that's a perfect segue into the next section, which is talking about the stem cell harvest. So it seems that what we're seeing a lot at our center is the peripheral blood stem cell source. And, we see the PBSCT is what we kind of see often. And then sometimes you'll see the bone marrow harvest and bone marrow source. And then occasionally you'll see this cord blood source of stem cells. Can you compare and contrast these sources for stem cells? And then maybe one other thing that I was asking actually that when we're talking about donors, the last question on that is, how does age impact? When you think about the donor age, is there a certain cutoff that's important?
All great questions. And now the fun part is that we're going to get into some topics where there have been actual trials that may be able to explain and answer some of your questions. So the question of bone marrow versus PBSC had been looked at multiple times, and certainly there have been more recent trials, but the quintessential trial that you'll hear about and that I think it drives a lot of our decision making was the BMT-CTN 0201 trial. This was an observational trial published in the New England Journal, I want to say about 10, 12 years ago or so, looking at PBSC versus bone marrow transplant for patients with mostly myeloid malignancies. And one of the questions one of the key answers was that there was no real survival difference in the outcomes, but there were some key differences in some of the secondary outcomes that kind of explains why. So there are a lot of advantages, which is why I think you see it used more and more. You tend to get higher yields of CD34 cell counts. You tend to get faster neutrophil and platelet engraftment compared to bone marrow harvests. It's less invasive for donors. It can be collected with growth factor stimulated apheresis as opposed to a surgery for the donor, which means theoretically more people might be willing to be donors. And I think that probably is borne out if you actually look back. And then particularly for myeloid malignancies, PBSC seemed to confer some amount of graft versus leukemia effect, more so than the marrow donation products. And like I said, there's also this factor of it being easier with donors, so shorter recovery times, less activity restrictions, better quality of life for donors. These are all reasons why I think it's become kind of the strategy du jour, whatever you have. If you have an option between the two and you're not worried about a couple small situations where you might get more benefit from the marrow, and we'll talk about those. That's why PBSC has become favored. One of the downsides, though, of PBSC was that there was more graft versus host disease, specifically more chronic graft versus host disease in that population. And that's what I mean by balanced secondary outcomes. So you have more graft versus leukemia and more graft versus host disease with PBSC. And so those seem to even out and yield a non-significant difference in survival compared to marrow transplants. And then the third source, which I think you mentioned, was cord blood. This is kind of comes from a different bucket. So it's collected in the immediate postpartum period. These banks are separate from the banks that tend to keep marrow donors in them. And there's a kind of a different population of where this is benefited from, that benefits from this. And a lot of centers don't do cord blood transplants anymore. There's only a handful of centers around the country that really have a lot of experience and expertise with this anymore. We've only done one or two in the last several years at Dana-Farber, and where some centers do this more regularly. And I think they've kind of found that niche for certain patients that need to have this. With cord blood transplants, the main advantages are rapid availability. So you don't need to wait to collect it from a donor. And there's much less stringent matching criteria. So we only think about really 3 of the HLA genes or gene loci that we use for matches. We use HLA-A, B, and DRB1 for matching cord blood transplants. So you look at 6 out of 6 donors, but not your typical 6 out of 6 that you'd think of for marrow transplants from back in the day. Some of the cons, though, again, there's limited availability. The cell doses are usually much smaller from an individual cord. So oftentimes you'll see double cord transplants, which is another bag of worms. They're very expensive. So because maintaining these databases are so high, a lot of those capital costs are passed off because unlike a marrow or peripheral blood transplants where you're collecting a fresh product or maybe freezing for only a very short period of time, these are frozen for years and years. And so that storage costs a lot of money. And so that gets unfortunately passed off here. As you guys know, cost is near and dear to my heart for many different reasons. There's delayed engraftment times compared to PBSC and marrow, and increased risk for infection partly as a result from that. And this all contributes to a higher transplant-related mortality and worse overall survival. And so this was also studied in the BMT-CTN 1101 trial or 1101 trial that compared haploidentical transplant to cord blood transplants, thinking of patients these were considered alternative transplants and really not practiced as regularly as they are now. And that trial showed that superior overall survival for the haploidentical transplant compared to the cord blood transplant. So that's another reason why that has fallen less in favor, or that is less in favor than it used to be.
So with that, we've gone through some of these important pros and cons to each stem cell source. And it's really interesting that the peripheral blood source kind of evens out that the bad GVHD to the good GVL effect, and there's no difference from that bone marrow source. So what are some scenarios where you would choose to do a bone marrow source for a patient?
Great question. So generally, times when you might consider using a bone marrow source are for patients that you're particularly worried about the adverse effects of graft versus host disease, and you're not as worried about graft versus leukemia. So the graft versus leukemia effects are more clearly defined and seen in myeloid malignancies compared to lymphoid malignancies. Generally for AML, CML, MDS, myelofibrosis, you're almost always going to see PBSC transplants. But for patients with lymphoid malignancies, sometimes you'll see those patients get marrow transplants, especially for patients that you're not as worried about engraftment issues. And then especially for non-malignant, I hate the term non-malignant, but for diseases that don't fall on that same spectrum of cancer, like say sickle cell disease or autoimmune diseases, those are situations where you're not expecting any graft versus leukemia. In fact, you're really replacing the marrow. That's the treatment. And so you really want to do everything you can to minimize late effects, and especially graft versus host disease. And so for those patients in particular, we almost always try to favor marrow transplants. And the other group is for really young patients, young recipients. Those are also patients that with non-myeloid diseases that I tend to favor going for a marrow transplant. And especially you'll see this in the peds world. I'm not a pediatric transplanter, but you'll see a lot more marrow transplants in that group for that reason.
Guys, I think that this sounds like a great place for us to take a break and resume this conversation next week. So until next time, we'll see you all later.
See you later.
Peace.